Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Michael Day. He's an orthopedic surgeon. Today's Kevin MD article is Why It's Time for Doctors to Become Performance Coaches. Michael, welcome back to the show.
Thanks for having me, Kevin.
All right. So I think you were last on a few years ago. And for those that didn't get a chance to listen to your prior articles, let's briefly share your story.
So I'm an orthopedic surgeon by training, and my subspecialty in that field was sports medicine. And so I have long time interest in performance and served as a team physician. And kind of in that vein, looking for performance for myself and my patients, I really felt that there was a gap between, for our orthopedic patients, completion of rehab, recovery from their injury, and return to performance. And that got me thinking about what our medical system does well and doesn't do well, and what gaps can there are that we could fill with alternative, more proactive and more preventative ways, and what we can learn from the sports performance world. So I've taken a new focus with my practice that focuses on proactive prevention and a performance-oriented approach. And so that's where that article kind of grew out of, viewing medicine through the lens of performance.
Mhm.
And I think a lot of the discussion in medicine is really, in many ways these days, about what is the role of the doctor and how is that changing. And so one of the ways that I like to think about it is, again, from sports and this idea of the performance coach, and how that can be an aspect of doctoring that really anyone can incorporate in any field of medicine. But I think that is kind of the thrust of the argument of that article, is that we should take on that role and provide accountability, expertise, and really build trust with the patients in the way that a good coach does.
All right. So let's talk more about that article for those who didn't get a chance to read it.
Yeah, I heard Dana White, who's a big UFC president of UFC, say, I'll never go to a doctor for medical advice. And I hear that, more frequently than I would have thought from people in my community. And as a doctor, it's kind of shocking at first, but if you pick it apart and understand where they're coming from, you can really understand where that sentiment comes from. There's a loss of trust.
Mhm.
There's, politicization of messages. There's conflicting messages. We haven't done a good job as a medical community of, taking ownership over medical information and the patient experience. And everyone's doing their best within the
Mhm.
limitations they have, but a lot of patients have experienced the deterioration of the experience, and there's so much health information that they don't trust the doctors to be on the cutting edge, and they don't want to wait for interventions to trickle through our typical system of randomized controlled trials and meta-analysis and the building of an evidence base, which we rightly rely on, but we need to kind of stay open to new therapies, and also individualization of
Mhm.
therapy, and looking at what works for each individual. Our evidence base often can tell us what'll work best for 1,000 individuals, but when we're one-on-one with a patient, we've got one individual that we're taking care of. And so I sympathize with that idea, and I think we can kind of claw back some of that trust. And so we need to meet the patients where they're at. And I think it's to our detriment if we dismiss those types of claims, and we dismiss the people that those people are following instead of doctors.
Mhm.
And we need to, add our voice to the milieu in a way that's not defensive and protective and exclusive, because we're not in the you know 75 years ago, where we're this gatekeeper of health knowledge and information. I mean, you know people used to get potentially erroneous information by just doing a web search. Now they're getting pretty good information by, the search is enabled by AI, and we see studies where AI is interpreting data in a way that's pretty comparable to a lot of physician level
Hmm.
functions. So that's something that I think we can do better, and I think the performance lens gives us an avenue to do that. The other thing that I talk about in the article is this idea that what's elite is not just for the elites in terms
Hmm.
of athletics. And this is very much a focus and lens of my practice. And I think that we learn from edge cases on both ends, and I use the example of type 2 diabetes versus elite endurance athletes. And they seemingly have little in common, but they're at either end of kind of a metabolic efficiency.
Hmm.
And so we can look to elite athletes not just for how they're training, and how their training may not be attainable because they may be professional, and we may have other demands on our time that are not going to replicate a professional athlete's training schedule, but particularly on like how the the their fitness is evaluated.
Hmm.
And so a perfect example is cardiorespiratory fitness, which is, as a category or an aspect of your health is central to any medical doctor's assessment of a patient, but also central to an endurance athlete's
Hmm.
assessment of their fitness. And so for my patients, I'm always encouraging them to get tested for VO2 max, which is the amount of oxygen they can extract from the air during exercise. And traditionally, this has been, a metric for endurance athletes and
Hmm.
kind of fitness junkies. But I think it's a primary care metric. Just like, you go to your primary care and get your blood pressure and your lipids and your weight and kind of these things that are benchmarks on at least an annual basis.
Hmm.
I think that the VO2 max can be that. And so it's an example of where something that has in the past been applied to elite performance can be applied to everyone. So I think everyone that wants to move and can move as an athlete, but even people that aren't, consider themselves athletes can learn about the relative fitness of their body from athletic metrics.
So you mentioned VO2 max as a metrics that should be measured. So what are some other ways that you could incorporate performance into what you do clinically in medicine?
Well, when I think about fitness and the components that the basic components that people are trying to incorporate into any kind of movement practice or fitness regimen, I like to think about the muscle component, the motor component, so cardiorespiratory fitness and mobility and movement quality. So there's tons of ways to measure strength, but probably the easiest one that I do for my patients because it doesn't require any specialized technique is grip strength.
Mm-hmm.
So I use a handheld dynamometer, pretty, $30 piece of equipment that you could even have at home if you wanted, but it's a good proxy for muscle mass, strength, even core stability. So lots of data supporting that as a athletic and longevity proxy metric. And if you're more familiar with modalities, you can test strength, in the weight room, or doing a dead hang from a chin up bar, or doing a wall sit. And so, if the patient doesn't have any orthopedic limitations or is otherwise, a safety concern, then we can get more detailed in how we test strength. But grip strength is one that almost everyone can do. And then mobility, I kind of my go-to test is the functional movement screen, which looks at 7 cardinal movements, and it's pretty low tech and can be done in a relatively small space. It's basically some PVC piping and a measurement device and a string to create a hurdle. So we can do that. If someone is working at home, there's self screenings like the Koji awareness self screen,
Hmm.
where you're just looking using a mirror and just no equipment other than a chair or a wall to perform some movements, and then you score it based on how far you can move in that position. So that's probably in that triangle
Hmm.
of motor, muscle, mobility, my three basic like VO2 max, grip strength, functional movement screen. which requires a professional to do it, or a Koji test if you want to do a self screen. And then you can get more detailed and geek out from there depending on
Sure.
their athletic experience and how detailed they want to get and whether they have sport specific goals.
So you mentioned earlier that one of the reasons why the public has lost trust in traditional medicine is that sometimes we're too slow to adopt some of these newer techniques. We have to wait for randomized trials. And I think in this day and age, we, like you said, need to be more nimble in terms of adopting some of these techniques and strategies into the exam room because that's what patients are looking for. Now, the reason I think that medicine has been a little bit more conservative is that a lot of times some newer techniques in the future have been found not to be effective or even harmful after being subjected to rigorous studies, right? So, how do you balance that tension between adopting what some of these physician influencers are saying on their podcast versus something that may eventually prove harmful when tested in the future?
Yeah, and that's affects our credibility too, because then you can't have it both ways. You adopt something new and it turns out to be wrong, and then here's the medical establishment subjecting us to harmful therapies. So I think safety has to come first when you're experimenting with doing these N of one experiments, and you don't always have you just have to, quite honestly, acknowledge the fact that you may not have the long-term view of this of how safe it's going to be, but you can make a reasonable assessment in the short term based on available knowledge. And that's the beauty of science, is that when you have new information, you revise your hypothesis and you change your opinion. And so I think we're unfairly criticized for flip-flopping or changing what we recommend, when that is the basis of the scientific method. So, I would push back against those criticisms. But I think when it comes to making the decision to prescribe an intervention or not, it's an honest discussion with the patient, trying to get them to understand what your best interpretation of the available data is, acknowledging where there's gaps in data, and then most importantly, just again going back to that trust and the willingness to adapt your plan
Hmm.
to the patient when it's not working or when it's harming them. Because, if someone understands the risks, they a reasonable person will understand that a therapy might not work out as planned. They're not going to accept if you say, well, if you put the blame on them, or if you say, well, this was something I told you, sorry. What they do want is someone that says, okay, this created this effect that was unintended. Here's what we're going to do to move forward or to get the result we want. And in some cases, there may be harm that's not reversible, and and we see that, most even more dramatically in surgery than in medical context, I think. But if we can, stay on the patient's side, that's the key to moving forward, I think.
So I think that performance coach mindset isn't necessarily being taught today in medical schools. And as you know, medical education is notoriously slow to change. Now, for those physicians who are listening to you right now and want to adopt more of that performance coach mentality that we're talking about today, what are some simple ways that they can do that?
They can ask their patients what their, performance goals are, and it doesn't have to be couched in those terms necessarily. In orthopedics, we were always taught in residency, if there's an upper extremity injury, what is their hand dominance, what is their occupation, and so it's kind of part of like a typical upper extremity injury presentation in orthopedics. You have this 37-year-old right hand dominant construction worker,
Hmm.
and then the mechanism of injury. And so I think taking that was so ingrained that it's like you wouldn't make a presentation about a hand injury without saying the hand dominance in orthopedics. But taking that a step further and saying not just what is their occupation, but what are their passions, what's their family situation, what are they most concerned about with their condition that they're coming to you for, what is causing their apprehension, is it because they think this is going to affect their ability to make money, or is it to take this vacation that they've been planning, or to have a certain way that they're going to show up for their family.
Hmm.
And so I think it comes down to just being more curious about our patients, which admittedly, the more of a time crunch we're under with, trying to take care of our patients in a timely fashion, the more difficult that is. But, the more just questions we can ask to get to know our patients better, the more we'll get an idea of what performance means to them. And then, we'll get to know them more as a person and facilitate building trust.
We're talking to Michael Day. He's an orthopedic surgeon. Today's Kevin MD article is Why It's Time for Doctors to Become Performance Coaches. Michael, let's end with some take-home messages they want to leave with the Kevin MD audience.
I think elite performance metrics are not just for elite athletes, and patients are looking for someone to provide not just expertise as we traditionally have, but accountability, support, and validation that they are not just buying into what has had traditionally been a paternalistic medicine, but that we can support them to take ownership of their health and provide some expertise and accountability and coaching support that will help them achieve their goals.
Michael, thank you so much for sharing your perspective and insight. Thanks again for coming back on the show.
Thanks for having me.